But Peter, I want you to talk to us about identifying triggers and protectors.
Yeah, it's a popular pastime, the identification of triggers, and the identification of protectors is a more recent development, you might say. I think people have been writing about triggers from almost since time immemorial. I mean, I tell patients if something reliably triggers your attack, you should avoid it, which seems like good advice, but hardly terribly insightful. I mean, I think there are two sorts of triggers. There are things that are easy to understand, you might say, that are, and for a trigger for me, it has to be reliable and biologically plausible. So nitroglycerin or alcohol and menstruation are sort of obviously, they're plausible, they're reliable, they're something you can hold on to. If you contrasted that trigger with chocolate, which would be the one we could most easily dismiss, which is neither reliable nor biologically plausible, nor actually stands up to any study that's been done. I think that sometimes triggers get mistaken for exacerbations of an underlying condition that irritate migraine. So celiac disease would be a very good example of this. If you have migraine, you have an unstable biology, basically. And that unstable biology can be tilted by altering another biology that you have, thyroid disease, celiac disease, whatever other biology you have, and that's referred to as a trigger. Whereas what actually is happening is simply your migraine biology getting irritated by some other biology. I don't think of that as triggering so much as comorbidity. I think that as we start to understand things, perhaps some of these things are going to fall away. Many of the food triggers will. I'm interested in some literature I saw recently on limonene, which is something you find in oranges, that apparently interacts with one of the mechanisms that CGRP will interact with. And so for some patients, you might almost think that all of a sudden oranges might make sense for some patients. But just like we don't have any therapy that's good for everybody, and nitroglycerin won't trigger everybody, nor will alcohol, and nor does menstruation. No one should be disappointed that if they get a list of triggers from some magazine, if they don't apply to them, I would worry about that, because the crucial thing is the interaction with the individual. So for triggers, I say to patients, if it's reliable and we have a discussion and it sort of makes sense, then you should avoid it. But otherwise, don't torture yourself. As for protectors, it's a more modern concept, I have to say. I think that at the moment, the things I've seen written about, that they're more likely to be statistical associations of less sensitivity to migraine rather than protection as such from the condition. So I think I would put myself into the slightly agnostic category when it comes to thinking about protectors. One underlying principle about this, and I think it runs through everything we've been saying, if you understand things and you start to dig apart the biology, then things that make sense, and the rest of it you can kind of get rid of. It's flat earth thinking. And migraine's come a long way in the last 25 to 30 years in terms of understanding detailed biology. I mean, we were talking earlier on about individual transmitters involved in aura, for example. We're going to talk, and we've started to understand these things in a way that it's the sort of old wives' tale migraine craziness stuff is going away. And it says that research works, particularly if it's funded, and it'd be better if there was more of the funding, we could say that. And it encourages us to think about patients with migraine as having a serious biologically determined problem. And if we could just understand what's going on, we'll do a better job and we'll be able to treat them so much better.
I often looked on some of the triggers as premonitory features.
Oh,
and my best example
Yes.
to my patients is you go out and eat pickles and ice cream, and you find out 4 or 5 days later that you're pregnant. Nobody thinks that pickles and ice cream will induce pregnancy. And the question is, the desire for something that you know might trigger your headache, you do it anyway. Is that really part of the premonitory features of migraine? And let's assume, for the sake of argument, that chocolate's a treatment for migraine. And let's say it's as good as the triptan. It works half the time. So you eat chocolate every time you get a headache, it works half the time, but you remember when it doesn't work and you blame it on the chocolate. So that's another potential.
Yes.
Well, the trouble with triggers also is what you said, blame, is the blaming. And
Blaming.
so often we as providers will use it to blame the patient. The patients will blame themselves. In another manner, they feel a sense of control. If they have a giant list of triggers and they can control some of them, even if there's no change in their underlying disease state, they feel like they're doing something actively. And that can be very harmful if they fixate on this and they don't, try to actually get appropriate care.
Totally.
And it actually goes back to what Peter said too. It's really important to have a conversation with them about the fact that a trigger is not a cause of migraine. As we understand the biology of migraine, when we understand more and more about what actually is associated with the genesis of migraine, we clearly understand that eating chocolate is not a cause of migraine. And the patients will often need a gentle persuasion in that regard.